Dr. Bleck has had a profound impact on the field of neurocritical care and has really been a guiding light for many of us in neurology, and not just neurology, but also critical care medicine, neurophysiology, lots and lots of different areas of expertise. I've actually had the privilege of working under Dr. Bleck during my neurocritical care fellowship now 25 years ago, actually. So it's been a little bit of a journey for all of us. He instilled a kind of a deep appreciation for the complexities of critical care medicine, neurology, kind of everything neurocritical care. I'm not going to review his illustrious past. It would take us quite a long time to go through all of his research, his writings, et cetera, et cetera. Just a little bit of quick math. If you look at his too many pages CV, he's probably written a article or a book chapter almost every single month for the last almost 40 years now. So with that introduction, I'm going to turn it over to the good Dr. Bleck, and he's going to talk to us today about status epilepticus and something new, but something old, and hopefully a treatment for status epilepticus. So with that, I will turn it over.
All right, George, thank you. Can you see my slides?
They look great.
All right. So I'm going to go through how we got to our current study, which will hopefully be starting around December, um, with a little bit of background really on how status works. The only things that are notable here are, I will mention rapid EEG. There are a couple of different companies that do it. I'm not going to propose one or the other. Just when I say rapid EEG, you should know I have been in working with Cerebell for quite a while. So I'm going to use the term anti-seizure drug, anti-epileptic drug. You know, we're not trying to kill epileptics. We don't actually stop the development of epilepsy. I know there are other abbreviations that use ASD. Occasionally I may slip up and say anticonvulsant drug because that's history, but these drugs do more than control convulsions. So as George mentioned, I've been doing this for a long time. This is my first paper. And for those of you who don't read cuneiform, this is the bottom line, even known to the Sumerians. People recently have tried to divide status into different stages. And although there have been some proposed times associated with it, the real transition from one stage to another has to do with drug response rather than an actual just time associated with it. So when patients have been seizing for more than about 5 minutes, it becomes very unlikely that they're going to stop seizing on their own. So that initial phase of status hopefully will be treated appropriately with a benzodiazepine. We'll talk about which one very briefly, but in general, a benzodiazepine will control about 60 to 65% of patients at this stage. If they fail a benzo, then they're in what we call established status, which is where the established part of ESETT comes from. And here we typically will use a conventional anti-seizure drug. The ones that were used in ESETT are the ones that are best studied, but you can really use many of them. If one of those drugs fails, however, then you're in refractory status. Now, some people want two of them to fail. There's not nearly as much data on, for example, what combinations might work better. We'll talk about that very briefly. But if you're in refractory status, then you're likely going to need general anesthesia for control. Now, this is dealing with either generalized convulsive status or, as the terminology sometimes goes, status with impaired awareness. I'm not talking about the person who has epilepsia partialis continua, whose thumb has been twitching for 5 years. It's going to keep twitching. Those people don't get general anesthesia for treatment. If you are controlled with a general anesthetic regimen, and then when you wean it, status comes back, then that's super refractory status. So we don't really have time to talk about that today, but It's something that consumes a lot of the concerns of neurointensivists. So this was the bottom line of the ESETT trial, the established status epilepticus treatment trial. This was a comparison of levetiracetam at a dose of 60 milligrams per kilo, fosphenytoin at 20 milligrams per kilo of phenytoin equivalents, or valproate at 40. In the past, people had given a typical dose of 500 milligrams or a gram of levetiracetam and wonder why it didn't work. So pharmacokinetic modeling indicated that we should use a loading dose of 60 milligrams per kilo. You can see each of these had essentially the same likelihood of stopping clinically evident seizures. So these were all people who had generalized convulsive status and improved responsiveness at 60 minutes. And this is important because some of the people, I'm sure, had stopped seizing, but because of their benzodiazepine dosing or because of being postictal, their responsiveness had not actually started to improve at 60 minutes. However, when we planned this study, we didn't have any rapid EEG systems available. So we don't actually know who had stopped seizing and just not awakened, a topic that we hope to deal with in our next study. So these numbers are sort of the floor. I think the real response rates are higher. We hope to, at least for levetiracetam, prove that in the next study. Well, what is status? In the past, people had said it's a continuous seizure that doesn't stop. Well, that wasn't very helpful. How long does it have to go on? Initially, people said 60 minutes, then 30 minutes, or repetitive seizures without recovery between them, which is actually most of what you see. Somebody who will have a convulsion, they won't wake up, and they'll have another convulsion. The best definition, I think, arises from the San Francisco pre-hospital status study. So if the patient was seizing when the paramedics were called and still seizing when they arrived, that was considered status. And on average, that was a little over 5 minutes. Now, what we don't know is how long they were seizing before the paramedics were called. There are estimates that people obtain, but we don't really know for many of these patients when it started. So here's when we actually moved this definition down to 5 minutes. Again, because it's very unlikely that a seizure that's gone on for more than 5 minutes is going to end on its own. The International League Against Epilepsy has now taken this and divided it into time 1 and time 2. For convulsive status, as we mentioned, 5 minutes is where we think that seizures are unlikely to stop on their own. Exactly when damage to the brain from status alone, as opposed to airway problems or blood pressure problems, occurs is debated. 30 minutes was based on animal work done back in the 70s and 80s. It's probably a little shorter than that based on what human data we have. Focal status with impaired consciousness, 10 minutes is typically listed. That's really a guess. And the 60 minutes was derived from a bunch of people sitting around a table drinking beer. Absence status is a very specialized condition, whereas everything else is really too much excitation. Absence status is a hyperinhibitory phenomenon, and it's unlikely that it's going to cause any damage no matter how long it goes on. So I already mentioned this. This is from one set of data, but there are many others where we thought when a seizure first starts, it's unlikely to progress without stopping. But as time goes on, it becomes less and less likely that it's going to stop on its own. If you look in seizure monitoring units where the patient's onset is really known well by EEG, those seizures typically last about 60 to 90 seconds. And this number is probably closer to 3 minutes out here. In children, it may be longer. Another way of looking at it is what happens in that San Francisco pre-hospital status study. So at time 0, when the paramedics arrived, the patients were randomized either to placebo, diazepam, or lorazepam. And the ones who got the placebo, which was done because nobody had given benzos to seizing patients out in the community long enough to know whether it was safe. You can see what happens here. So about 20% of them stopped seizing by the time they got to the emergency department, but 80% were still seizing in the placebo arm. So you can think of this as what's likely to happen without treatment. Again, we don't know where out here the seizures actually started. But when they get to the emergency department, then they get some more definitive therapy. Diazepam was sort of an intermediately effective drug, and lorazepam was the best, controlling 60%. So I think this tells us a couple of things. One is that these drugs are clearly better than a placebo. And secondly, that even when they get to the emergency department, the ones who have failed the benzos in terms of stopping status are still easier to control because they have been treated earlier. And I think uh, with an election coming up, remember the Chicago election rule, which is vote early and often. So you want to treat these patients early and, if necessary, often. So this is the proportion you consider refractory to diazepam or to lorazepam. But in most studies, again, it's going to control 60 to 65%. These are data collected from children where 12 minutes was approximately the point at which seizures were unlikely to end on their own. But uh, the duration was collected primarily from families or bystanders, for whom 1 minute of seizure activity looks like an hour. So I wouldn't really take this with too much veracity. Well, everybody can have a classification of status. This is mine. The patient's in status. The patient's not in status. I'm not sure if the patient's in status, and this gets into the so-called ictal interictal continuum that we don't have time to deal with today, but I'm not always sure when I look at an EEG in a patient whether I'm looking at status or not. And my bias is to give some initial treatment if I'm not sure and see what happens. And let me just say that post-anoxic myoclonus without evolution is not a form of status epilepticus. It doesn't respond to anti-seizure drugs the way that status does. There are some myoclonus treatments to which it may respond that also have anti-seizure effects, but I'm not going to deal with this further, but this is not status, and that's not what I'm talking about. Well, treatment for status actually goes back into the 1850s. I won't go into the whole history, but Locock thought he could stop seizure patients from reproducing since they thought epilepsy was hereditary by giving them bromides. Uh, what he realized, however, was that some patients put on bromides stop having seizures. And this was really the first actual treatment for status. The introduction of benzodiazepines in the mid 60s was a giant step forward in the management of status. Uh, Interestingly, Gastaut and Naquet, even back in the mid 60s, were able to sort out most of what we were looking at and describe what we see today. But even in the mid 60s, they knew that you needed an EEG. Of course, back then, rapid EEG wasn't available. Lorazepam was introduced in the mid to late 70s, and their initial dose in this study was 4 to 8 milligrams, which was effective in the majority of the patients. Seizures might recur, but nobody went back into status. So this has led to, I think, an underdosing of hospitalized patients. This is really what's probably appropriate for outpatients rather than for inpatients. The next major breakthrough was the VA cooperative trial for the treatment of generalized convulsive status run by Dave Tryman and colleagues. Interestingly, they had a somewhat relaxed view of how to obtain consent from patients who were in status. If they couldn't reach a family member, they just said, well, these are all approved drugs. We're just going to go ahead and do it. Notice the doses that they gave. They gave lorazepam at 0.1 milligrams per kilo without a cap for weight. So even though in the ESETT trial, for example, we were forced to have a cap of 4,500 milligrams for levetiracetam, I would think that not having a cap is probably more appropriate based on our older data. But these were the doses of drugs that were given in this trial. You might expect them to be effective. Interestingly, lorazepam, phenobarb, and diazepam were all essentially the same, lorazepam being much easier to administer. I was taught to give phenytoin because it wouldn't be sedating. Well, it turns out that a loading dose of phenytoin is sedating, that there's really no difference in side effects among these. So if you look at the individual arms, we'll only deal with overt status. Subtle status is a condition where either the seizures had been going on undetected for a long time, or the patient had some degree of pre-existing uh, cerebral damage that made them more difficult to control. Again, lorazepam in the 60s for response rates. Phenytoin, the statistical outlier here. Sorry. But I think more interestingly is the subset of patients who got EEGs hooked up very quickly. So those who had a discrete seizure followed by postictal slowing, followed by another seizure, uh, responded to 75%, 75% of them responded to whatever treatment they got. Whereas if the EEG had evolved into a period where the seizure activity waxed and waned but never quite went away, that response rate for all drugs in aggregate was already down to 30%. And if there was an invariant seizure pattern, 24%. If there are any suppressions in the record before treatment, then it's unlikely that even lorazepam or any of these other drugs was going to be effective. I don't think it means that the EEG by itself predicts the response to drugs. I think it's the duration of seizure activity before the drugs are given that is important. So treat early and often. So if we look at the individual arms, if lorazepam worked, great, but if it didn't, then the patient got phenytoin. This was a very cleverly masked trial so that people didn't know what they were giving. But phenytoin only got another 7%, and if those two failed, then phenobarb only got another 2%. Now, in order to assess whether the drug was successful or not, usually without an EEG, they would wait for between 20 to 60 minutes before going to the second arm, which we wouldn't do anymore. So it's likely that the poor performance of the other drugs was at least in part related to the duration of seizure activity when it couldn't be controlled with, in this case, lorazepam. This was the phenobarb arm. If phenobarb worked, great, but if not, then you got phenytoin, and you can see again how bad these other drug responses are. So, for example, lorazepam, which looked great in the first position, if the patient got diagnosed
Dr. Bleck, for some reason, I'm not hearing you at the moment. All right. It appears Dr. Bleck was having a little connectivity issue, so I assume he's going to be logging back on here in just a moment. Thanks for your patience. Thanks, everybody. Dr. Bleck just said he's restarting his Xfinity internet connection. So thanks for hanging with us. Hopefully he'll be back on here in just a moment.
Yeah, he's in Florida these days. So he probably has the cheaper version of Verizon.
Yeah, he
Trying
said that
to,
the internet is a little bit spotty where he's at, and that he said it was up to Xfinity if he would be able to get back on.
Hello.
Hi.
Sorry, the Xfinity is a problem down here. All
Well,
right,
sorry that happened.
let me see if I can get back to where we were. Okay, shall I just continue from here, or do you want me to reschedule?
No, that would be great. You can go ahead and keep going.
Okay, so at any rate, in 2007, we were able to set up the actual centers for the network here. And this required a couple of different trials to be proposed. One was called PROTECT, which was a trial of progesterone analogs in head trauma, which didn't work out, but Rampart was the one that turned out best. And this is Bill Barsan, who was the head of NET and later of Siren. This is a hub and spoke model. The sort of maroon things here are where the hubs are located, but they each had many spokes. Rampart was a trial in the pre-hospital setting to compare intravenous lorazepam to intramuscular midazolam. It was funded by the Department of Defense because they wanted to know if intramuscular midazolam would work in status because nerve agents, if you survive the pulmonary uh, toxicity, will produce refractory status quite routinely. And they were afraid if soldiers were exposed, they would need some treatment that could be given through their protective gear without having to start an IV. So they actually passed the funding on to the NIH to run the study. This was the major report for Rampart. And what was interesting here was not only was intramuscular midazolam effective, it was actually more effective than intravenous lorazepam. There are a couple of reasons for that. I think the most important one is that treatment was given faster. And again, the faster the treatment, the more likely it is to work. The other thing is, of course, that it took time to start an IV, right? So here, this was the amount of time that it took to give the intramuscular injection, and this was the mean time for the intravenous injection because you had to start the IV. So midazolam more likely to be effective, and it was effective faster. From the time that you actually gave the drug, the IV lorazepam was faster. Notice the doses here. If you were 40 kilograms or higher, you got either 10 milligrams of midazolam or 4 milligrams of lorazepam, which could be repeated once. For subjects who were between 13 and 40 kilograms, they cut the dose in half, which sounds silly, but in fact works pretty well because the smaller you are, the more likely you are to metabolize the drug more quickly. So this was the kit that we used. Everything was packaged, including a talking clock recorder. So the paramedics giving the therapy didn't have to write down or remember anything. They would just say, I'm starting the IV, I'm giving the IM injection, I'm giving the IV injection, so that we knew the actual times at which things were done. So we can be quite confident that the drugs were given as said. And so we actually won the 2012 clinical trial of the year for this study. And this is Rob Silbergleit, who's the spark plug behind all of the studies. I'll skip over this for now. Because of this, midazolam got an approval for status, but it got the worst brand name in the history of medicine. There are other ways perhaps to give midazolam. You can give it intranasally, intrabuccal. Now there's this needleless auto-injector that's available. So we really think that if the patient doesn't have an IV, they should get intramuscular or intranasal midazolam. There's not a good comparative study between the two. Just to move through this pretty quickly, after 5 years, the funding for NET ran out, and we now have Siren strategies to innovate emergency care clinical trials. The idea here is this is a combination of the NINDS and the National Heart, Lung, and Blood Institute. So again, all these studies are going to be somewhat resuscitative. So Siren goes here. So we started planning for ESETT in 2013. I think it's interesting that the trial took so long between when we first started planning it and when we were actually able to conduct it. This is the steering committee for ESETT, which proves without a doubt that I'm the tallest. So you might wonder what the budget for something like this is. ESETT's budget was a little over $21 million. The budget committee, or the committee, thought the budget should be increased to include EEG, but we knew at that time that we didn't have an EEG system that could be attached quickly enough to make it worthwhile. So our primary objective was to determine which of the three arms was most effective in treating benzodiazepine refractory status. And we also had a number of other outcomes. So we had planned on a Bayesian randomization, but in fact, the difference between the drugs was so small, we never met the criterion to sort of play the winner and randomize more people into the drug that was most effective. And we'll skip over this because I ran out of time here. What we had suggested, though, was to give a decent dose of a benzodiazepine. However, what we found was that people, instead of giving a full dose straight up, skip over to this now, we're giving little spritzes of a benzodiazepine. I'll come back to that in a minute. So again, the FDA ordered us to cap the doses. This had more to do with how much fosphenytoin they thought might be safe to give. But in order to keep everything randomized without unmasking the investigators, everything was capped here. Now, it's likely that you don't need to give the whole 60 milligrams per kilo because we had patients who were over 75 kilos who responded to each of these drugs, suggesting that maybe these doses could be lowered a little, but they were safe. And until we have more information, I would stick to these doses. And since levetiracetam has now gotten approval to just inject from a syringe rapidly instead of having to use an infusion pump, there's very little reason to pick one of these in general. There might be an individual patient difference that would lead you to think that one might be better than the other. So, I'm going to skip ahead here. So this is how people actually got benzodiazepines. They would get little spritzes instead of getting the whole 0.1 milligrams per kilo of lorazepam, for example. And eventually the investigator locally would decide, well, this is not working, and would randomize them to ESETT. So we were criticized by the emergency medicine community for saying, well, you didn't let us know how many patients got a full dose of benzodiazepine at the start and were therefore successful, never needing to go into ESETT. Well, that's true, but we were studying benzodiazepine failure. It may well be, and I think it is probably true, that if you got a good dose of benzo right at the start, you wouldn't progress and you might not need the ESETT drugs. So interestingly, if you were a kid whose parents had Diastat at home, you were much more likely to get the full dose at the start of treatment than either midazolam or lorazepam given either by the emergency department or in the pre-hospital setting. So we had a stopping rule that said at 400 patients, the DSMB would look at the data, and they said that, well, at this point, it does not appear that there'll be any useful difference among the drugs. So we stopped enrolling adults. We kept on enrolling children, but in fact, when we enrolled another year's worth, there was no clear difference between the drugs. This was the box that was used. It had a drug plus this iPhone, which was, again, set up like the ESETT, I'm sorry, like the Rampart one, to be able to remind people what to do and collect data on when they did it. Of course, you only got one drug per kit. So when this was studied, finally, what we discovered was that there was no clear difference among the drugs. But again, as I mentioned before, there was no EEG assessment to know for sure whether they had stopped seizing or not. This is how the success for the three drugs worked. Again, the means are around 46% here. In terms of side effects, the one interesting outlier here was intubation of patients who got fosphenytoin. There's no clear pathophysiologic reason why that should happen. And when we went into this in more detail, as you'll see in a minute, the main indication for getting intubated was you're in a center that intubates a lot of people. Either they get intubated before they go to CT scan, or they get intubated so that they can get an ICU bed. It's really a problem in terms of using intubation as an outcome because the criteria for intubation are so wishy-washy. We did break the patients down into different age groups in which you might say, for example, that in adults of middle age that fosphenytoin, I'm sorry, that levetiracetam was least likely to be effective, whereas fosphenytoin was more likely to be effective, but now we're getting into pretty small numbers. And there's not enough difference between them to say that, yet at a particular age, you ought to get a particular drug. So Eric Rosenthal at MGH ran this analysis where we looked at why people got intubated. And as I mentioned before, they get intubated because they go to centers that intubate a lot of people. We looked at the development of seizures after initial control. And just because you responded to the drug in the first place doesn't mean that you're out of the woods. A lot of the patients actually went on to seize in the next several hours again, so they need EEG monitoring and treatment for those seizures. So I'll talk about KESETT in a minute. This has now been approved by the NINDS, and we're expecting funding to start in December. As I mentioned before, the rapid EEG, I think, will be useful in determining whether or not patients have stopped seizing when they're no longer convulsing. So it's easy to go from convulsive to non-convulsive status with treatment, but it's also possible that even though they weren't convulsing, they were no longer seizing, but were sedated by the drugs or they're postictal. So we need EEG at this point to figure out whether they need further treatment. We've been trying to look at how rapid EEG devices influence behavior in the emergency department. Unfortunately, this study didn't get funded, so we're looking for another way to pay for that. One of the newer approaches here that we have tried to use is the so-called desirability of outcome ranking. So rather than saying seizing or not and waking up or not, we'd have, for example, the best outcome would be no seizures either clinically or electrographically. The patient wasn't intubated and they're starting to wake up by 60 minutes. So that would be considered the best outcome. However, if they're not seizing, they're not intubated, but they're not improving mentally at 60 minutes, that's not as good as this outcome, but would still be a reasonable outcome. Or they don't have seizures, but they got intubated or they got another drug. Well, that's not as good as these, but it's better than still seizing. And all these are better than having an adverse event. So we had proposed for KESETT that we would use this scale, but both the FDA and the NIH decided that they wanted a binary outcome. So instead of talking to you a lot about how this would be a better way of doing it, we're going to use that as a secondary outcome. So we were lucky enough to get a good funding score here. The estimated cost for this study, of course, there's been inflation, plus we need to get the rapid EEG equipment, will be about $30 million. Now, we have approval, but we don't know yet what the final budget approval will be. We should find out in December. Pretty much everything is getting scaled back because the NIH is running under a continuing resolution, and of course, the outcome of the election may determine how much more or less money the NIH is going to get. So they're concerned now about overcommitting and running out of money. So after the election, we'll find out more about this. Well, people have started using ketamine for the additional control of status, but what our study is going to look at actually is taking patients who are benzodiazepine failures and randomizing them to levetiracetam alone at 60 milligrams per kilo, levetiracetam plus 1 milligram per kilo of ketamine as a single dose, and levetiracetam plus 3 milligrams per kilo of ketamine as a single dose, looking to see whether these relatively lower doses of ketamine have an anti-seizure effect separate from the general anesthetic effect, which would kick in around 5 milligrams per kilo of ketamine. It's often been speculated that ketamine works primarily here as an NMDA antagonist, which we know it does. It probably has other effects that kick in at different doses. But our study is really to see, does ketamine at these lower doses have a useful anti-seizure effect that might prevent patients from going on to needing a more vigorous general anesthetic regimen. So I know I kind of rushed through that because of the loss of time, but that's the end of the talk, and I'd be happy to take questions.
Thanks, Dr. Bleck. No worries about the internet. We totally understand coming from the state of Florida these days. I'm glad you left Chicago in time and voted twice. Um, so I'll take the liberty of asking the first question. So what's known in the literature in terms of the use of ketamine, for example, in specialized disease states? So we are a big referral center for much of the state of Washington. So we get kind of bizarre um, case presentations, patients with autoimmune encephalitis, for example, super refractory status epilepticus. Is there any data in the literature in the use of ketamine for kind of these more rare causes of status and refractory status?
Yeah, so as far as super refractory status, almost everything that's out there is in case series or individual case reports. Um, it's widely used in that setting now, either as a way of avoiding other general anesthetics. Uh, for example, a lot of people use pentabarb or phenobarb, uh, or use higher doses of propofol, uh, either substituting ketamine for that or using it in addition to those drugs to try and decrease their doses. I'd say it seems to work. One of the interesting things about ketamine is that it by itself will not produce a burst suppression EEG. Uh, so if people think of burst suppression as a goal, that's only a goal for barbiturates and for propofol. Benzodiazepines will sometimes produce a burst suppression in a brain that is already highly damaged, but in a normal brain, it won't. So again, what you're going to pick as a therapeutic endpoint is quite important based on whatever drugs you're giving. But as far as I can tell, there is no human study that looks at these doses to see whether there's an anti-seizure effect separate from any other general anesthetic effect. The autoimmune encephalitis question is quite interesting because anti-NMDA receptor encephalitis in some sense mimics the effect of ketamine rather than being something that would likely be treated by it. In that some of the patients with anti-NMDA have decreased activity at excitatory amino acid synapses, which is what ketamine does. Whereas others seem to have an activation of them and would respond to ketamine, and there's really no way to know which is which until you give the drug and see what happens. But for patients with NMDA receptor encephalitis who are not actively seizing, ketamine will probably just make them worse. So I would only use it when the seizures are hard to control.
Interesting, interesting. Let's see, Mike Doherty. I don't know if you want to ask yourself, or I'm happy to read your question. I see it in the chat. So Mike Doherty is head of our epilepsy group.
Yeah, Dr. Bleck, how do you find the Cerebell is being used or the rapid EEG is being used in your institution? How are you advising your fellows and students to use it? For us, it seems like the best use is a very blunt status, yes, no. I'm curious to see what you're finding at Northwestern there.
So even though I've done a lot of work with Cerebell, we don't have it. We had machines on loan during the height of the pandemic to use for sedation monitoring, which I think is also a possible use for it, although um, I'd rather have a regular EEG. I think what we found at that time was that most of the people who were agitated and requiring high doses of sedative medications to stay in sync with the ventilator were not seizing. Did it help us to titrate drugs very much? I don't think so. We ended up loading a lot of people with phenobarb when nothing else was working, and that was our observation. Now, where there are published studies looking at what rapid EEG does out in the community, for example, I really agree that it's mostly a are they in status or not sort of issue. Secondarily, if you look at the recordings yourself, you can see whether people are having intermittent seizures that don't reach the machine learning criterion for status. But when it's being used outside of neurologic units, it's probably most useful is it status or not. When we had it, we would download the data into the regular EEG system, and the electroencephalographers would interpret it. But when I personally have played with it, I don't really care what the machine learning says. I just want to look at the patterns. So we'll see in patients in settings where there is no one around to interpret the EEG, I would only look at status or not. So in terms of what other devices might be used, because I've worked with Cerebell, I've stayed out of that discussion. I think the Zero device looks promising. There are a few others that are in the pipeline, but it won't be my decision because I've worked with Cerebell. Patients with first time seizures, the study protocol doesn't distinguish whether these are new onset seizures or people who have pre-existing epilepsy. So I'm not sure that I understand Dr. Lopez's question beyond that. Maybe there's more to it I should answer.
Any other questions from attendees?
I'm sorry, TKS, what did you want there?
Not sure what that means. TK.
I think it means thanks.
Oh, okay. Thank you.
That's not a millennial or a Gen Z. I'm not sure what that is.
I see all sorts of abbreviations I don't understand anymore. Dr.
It looks like Dr.
Massaro.
Massaro had a question in the chat box too. If you scroll up before Dr. Doherty's.
Right. That was to do with which point of care device will be used, and I really stay out of that discussion
Okay.
because of my connection.
No conflict. We got another. Have you started seeing more and more ketamine use in the neurocritical care units at
Oh,
Northwestern?
absolutely. We use a lot of it now in refractory status. I would like to say that I know how to use it, but often these are patients who've been seizing for a long time. They come in on 4 drugs already, and whereas we're trying to use ketamine to control their status and wean them off of more toxic things, they're also variable. I can't say that I have learned the way to use it.
And what doses? I'm just curious. Kind of a ballpark range from low to high.
Yeah, so
Probably more high.
I think people are starting with probably in the range of about 20 milligrams an hour, 20 milligrams per kilo per hour, sorry. But there's really no way to determine what you ought to do. The general anesthetic dose is usually held to be about 5 milligrams per kilo, which, if given as a single dose, will last about 20 to 30 minutes. So the other thing about ketamine is that 70% or so of the reported status patients treated with it will get an increase in blood pressure because you'll get release of endogenous catecholamines. So I actually started using it not because I was a great pharmacologist, but because blood pressures were often low from the other drugs, and I thought it would be good to have one that could raise the blood pressure. The
And you
NMDA
mentioned,
effect is probably the important one, but the patients who've been on pressors for a while probably won't see much effect of that. In fact, there is a slight myocardial depressant effect that may show up if they've exhausted their endogenous catecholamine stores.
yeah, you mentioned ketamine will not induce a burst suppression pattern, and I certainly don't have time to get into the debate of using burst suppression as a means to treat super refractory. But how are you, I guess, titrating then?
Well, I think
Once they've stopped.
if you're going to start a barbiturate or a propofol, for example, or increase the dose of propofol, then going for burst suppression is a reasonable initial goal. The only study that really looked at this in detail was done a long time ago at Beth Israel in Boston, where they looked at the background necessary to control seizures, and there were a fair number of patients in whom burst suppression itself was not sufficient to stop them from seizing. Now, one of the things we don't know is having a few brief seizures deleterious in terms of the brain itself or of getting control of status. I don't try to eliminate every seizure anymore. I used to do that, but there's probably no real advantage to trying to get rid of every seizure for 12 or 24 hours. But again, it's a real unstudied question. If you're going to use just high-dose benzodiazepines, recognize, though, that there's a lot of tachyphylaxis to it. So if you started, say, at 0.2 milligrams per kilo per hour, you're likely to increase that dose tenfold or more in the next 24 hours because the benzodiazepine receptors that are sensitive to things like lorazepam are being swapped out of the membrane for GABA receptors that are not sensitive to benzodiazepines. At the same time, you're getting an increase in the number of excitatory amino acid receptors in the postsynaptic membrane, which argues in favor of something like ketamine or perampanel, which hopefully perampanel's intravenous preparation will be coming out in the next year or two, which I think would be quite useful.
Well, I'm not going to take up more of your time. We really appreciate taking the time out of your busy schedule to give us your view on ketamine and what the future might hold. And good luck on grant funding. And like you said, vote and vote often. And we will see what happens. And good luck on funding. And we will stay tuned.
All right. Thank you very much.
Thanks, everyone. Bye-bye.